This is Steve Lewis. I'm doing a talk on spinal cord compression, which is part of compulsory training. When you've been through this, could you please complete the questionnaire and then email the result to me so that I know that you've seen this presentation. Okay, so spinal cord compression in oncology patients. First thing to remember, of course, is that we're dealing with a pediatric population and therefore normal pediatric rules apply. Second thing is that whenever you're dealing with an emergency situation, normal rules of resuscitation apply, so A, B, C and disability is really important. And then the third thing to say is that oncology patients are different from the general population because we have so many other things going on in this group of patients. And particularly, and especially in newly presenting patients, they have an unstable tumour environment and we have no idea how much tumour is in the patient, so we don't know which organs could be presented. When you have tumours presenting, there's often invasion of normal structures, so they are intrinsically more likely to go wrong. Many patients have bone marrow failure, and therefore you get bleeding as a significant complication which can make things worse. And then finally, we do many things to our patients, but in particular we do lumbar punctures and we use intrathecal chemotherapy, and all of those can be associated with causing complications that affect the spinal cord. About 5% of oncology patients will develop cord compression at some time from the moment they're diagnosed to the moment they're either finished treatment or eventually die of their disease. So that could be at presentation or at relapse. Very often it's not, it's in the context of palliative care. We need to think a little bit about the anatomy of the spinal cord, and whilst I don't want to go into great detail, the purpose of this picture is to show you that the spinal cord is encased in a very thick bony structure and there is very little room for manoeuvre should there be any increase in volume within the spinal canal. What I will do though is just go through the vascular supply to the spinal cord, because that is the key component here when we're considering what to do with acute compression. So this is taken from a very good website called anatomyzone.com, and it's certainly worthwhile having a look at this if this isn't a good enough presentation for you. So if we look at the vascular supply to the spinal cord, we have three arteries which run the length of the spine from top to bottom, and those are the anterior spinal artery and the two posterior spinal arteries, and they provide a supply of blood all the way along, so there is a cross flow between vertebral levels. In addition, we have a segmental supply coming from various other structures. So for example, in the thoracic level they come from the intercostal branches of the arteries. Lower down there'd be lumbar vessels. So the segmental artery comes in the lateral aspects of the spine and then divides into anterior and posterior radicular arteries, and these pass along the nerve roots and supply the cord itself from those two aspects. In addition, and somewhat variably, you may get segmental medullary arteries which directly supply the anterior spinal artery, and of course all of this is bilateral, so you have a really quite extensive network of blood vessels supplying the cord. What's perhaps surprising therefore is that this vascular supply is easily compromised, and most importantly that if you get a block at one level you can lead to infarction relatively easily. When you're thinking about spinal cord compression, it's helpful to think about the context in which this arises, and I've divided this up into intramedullary, intradural and extradural. So intramedullary means arising from within the spinal cord itself. Intradural means arising outside the spinal cord but within the dural cavity. And extradural of course means coming from the outside of the dural sac from elsewhere. So if we look at the different causes, intramedullary is usually due to an intrinsic spinal cord tumour, and those are most commonly low-grade astrocytomas or ependymomas. Very occasionally you get other ones, but those are the more common ones. Intradural compression usually arises from deposits of disease which are metastatic, and by that I mean lumps of leukemia or lymphoma or brain tumours with metastases, but occasionally of course you can get infection and you can get aspergillomas or TB causing the same problem. And extradural compression tends to come from things poking from the outside inwards, so that could be due to bony collapse, and that's often in the context of metastatic disease, or from primary tumours of the vertebrae. Most commonly that would be a Ewing's tumour, or from tumours which are poking in between the vertebrae, so they would be things like neuroblastomas, sarcomas, neurofibromas, and occasionally meningiomas also. The differential diagnosis of those causes of cord compression are also not benign. In a patient who's had radiation previously, then radiation myelopathy or radiation necrosis is a possible important diagnosis not to miss. After spinal surgery, patients can indeed infarct, and very occasionally you get acute demyelinating encephalomyelitis, which is still rare but described. Extradural causes include other causes of vertebral collapse, osteoporosis being one, LCH is another. Infection, an abscess, and often that used to be TB of course. Disc prolapse itself can cause extradural compression, and you can get vascular malformations as well. And then the other causes, non-traumatic causes, are various, but again, none of these are trivial diagnoses to think about, and it's important therefore to investigate anybody who you think has got compression, regardless of whether you think this is due to an oncological cause or not. What are the presenting features of cord compression? Well, I think if you just remember three things: pain, neurological deficit, and postural change, that might get you thinking down the right route. If you look at the symptoms of and signs, then back pain is probably the most common, weakness is the other, local tenderness, but also sphincter disturbance, which tends to be a little later, other sensory disturbance, and then disturbance of gait are the principal features. The signs and symptoms depend on the site and which nerve roots are affected, of course. It also depends on the speed of onset. So if you have a very slow increase in the compression, you may get a degree of compensation, and you may get larger tumours which have developed alternative vascular supply, so you don't get an acute infarction. So therefore, it also depends on what the pathological cause is. So you could have a low-growing intrinsic spinal cord tumour which has been around for several years, or you could have an acute lymphoma causing acute compression, and they would present in a different way. And then very importantly, the involvement of the blood supply is a major determinant of how the patient presents, because the moment you get an acute loss of blood supply is when you get a severe deterioration of symptomatology. Pain can be due to bony collapse, and you'll get localized tenderness with that. Muscle spasm is common, and again you may get some local tenderness, and then you may get nerve root irritation, and you may get central pain, lumbogirdle pain, or you may get Lhermitte's sign, which is sort of lancinating pains going down the neck. It is said that pain is made worse by straight leg raising, or neck flexion, or valsalva, or cough, and those are of course likely to increase movement of the spinal cord, and therefore if there's any tethering cause things to be worse, or to increase intracranial pressure and intraspinal pressure. Note that pain can cause blood pressure to be elevated, and if you relieve pain, you may actually get a rapid reduction in blood pressure, and if the patient becomes hypotensive, then that in itself becomes a problem, and I'll explain that in a moment. Other symptoms and signs, well, a neuromuscular deficit, which would be either a weakness, a sensory level, or loss of sphincter function, are really important to identify early. And of course you have to pay attention to the distribution of dermatomes. So be aware that if you're thinking about someone who's got cord compression, to look at their dermatomes properly and make sure you do test each one of those. And that unfortunately means examining around the anal region as well. Posture is important. Scoliosis is really quite common in patients who have low-grade spinal cord tumours, such as the patient here whose scoliosis is displayed. Then you may get quite gentle angulation, but very significant. In patients who have acute severe pain, then you often get a functional scoliosis due to muscle spasm. How do you investigate these patients? Well, a plain X-ray is not really going to be very helpful, although we often do it. but it's only abnormal in about a third of patients as opposed to 85% of adult patients. So plain X-ray really isn't the investigation of choice. A CT is enough to give some idea for immediate management, but really MRI is the investigation of choice. How to manage cord compression? Well, I said at the start that this is a paediatric problem and normal rules apply, so A, B, C, D. Airways and breathing ensure that the patient is ventilating normally and is saturating properly. And the reason for this being particularly important is that if you have high compression, then of course you may lose function of the intercostal muscles or even of the phrenic nerve. So the pattern of respiration is important to assess. Make sure the circulation is normal. The key thing here is to make sure that blood pressure is maintained and avoid hypotension or shock. And then your assessment of disability is really firstly to assess the level of consciousness of the patient, because this could be part of a wider process. So you may have a diffuse involvement including the brain and the spine, and the patient could be hypoventilating or could be having evidence of compression within the brain and therefore have an incipient emergency separate from the spinal compression. So we assess level of consciousness according to the Glasgow Coma Scale, and that's a separate talk, but just be aware that understanding the Glasgow Coma Scale is important, and if you want to do a rapid assessment, then AVPU is a perfectly reasonable way to start. If you look at raised intracranial pressure, the key factor here is that you're trying to maintain cerebral perfusion pressure, and that's defined as the mean arterial pressure and then you subtract the intracranial pressure from it. So the cerebral perfusion pressure normally runs at about 70 to 80 millimeters of mercury. But of course, if you start getting a volume increasing within the brain, then there comes a key moment at which the intracranial pressure starts to rise very rapidly. And indeed, people have done studies with intracranial pressure monitors, and they find that if you have a GCS of 13 to 15, then that probably means that your intracranial pressure is low, less than 20. But if your GCS is less than 8, and that's the point at which you probably only respond to pain, then that correlates with a pressure of greater than 30. So although our tools to assess it are crude, they do at least have clear indications of when you have to act promptly. So that's the situation for cerebral perfusion pressure, but we can really change this to a similar situation within the spine, because the spine is also a firm box with soft structures inside it. So spinal perfusion pressure, mean arterial pressure minus intraspinal pressure. And think about it in much the same way as you would for a raised intracranial pressure. So how do you manage raised intraspinal pressure? Well, you make sure that the patient is adequately oxygenated and you correct hypotension. So you're trying to ensure adequate delivery of blood that is oxygenated to all parts of the spine. Positioning of the patient with spinal injury is probably more important than with raised intracranial pressure, because venous drainage is rather more complex and it is possible to cause occluded venous drainage. So a neutral position, and one where the spine itself is stable, because clearly a patient who's got an unstable spine could get further complications, is going to be important. And then you reduce edema, and the way that we do that now is to use hypertonic saline, but mannitol is an alternative, and dexamethasone. And of course you would make sure that the patient hasn't bled or isn't likely to bleed with any intervention, so check their platelets and their clotting. And then you investigate the cause. And as soon as you find out what the cause is, you treat it. So that may involve surgical decompression, or radiotherapy, or chemotherapy. So here's a patient who has extradural compression. You can see that down at the base of the spine. It's not the best imaging, perhaps. Here's a separate patient who has an intrinsic spinal cord tumour, and I've highlighted the area of cystic degeneration, but actually the tumour itself extends well above and well below where we're recording there. Here's a patient who had an anaplastic astrocytoma who presented with an abnormal gait but was otherwise quite well, and I'm sure you can see that there is a very significant swelling of the upper thoracic spinal cord, but also there is some cystic degeneration lower down, and the area where the cord is very fat, you can see that there really is no CSF passing through. So this was a critical cord compression. And this is the same patient who was treated with resection but subsequently recurred, although actually with further treatment has managed to develop no further cord problems, and apart from developing a scoliosis in later life and that being corrected, has had a normal life since. This is a patient with a medulloblastoma who had spinal cord metastases, and that's a fairly typical appearance of a mixed signal metastasis arising over the back of the spinal cord. Here's another drop metastasis in a patient with medulloblastoma, although ependymoma is perhaps more commonly the case. So this is a lesion which is presenting at the level of the cauda equina. This is someone who probably would have had an area of saddle anesthesia or possibly of pain in that area. Here's another patient with extensive intracord metastatic disease. So again, this is down at the level of the cauda equina, and what I've identified is the white areas are tumour, and if you look at the bottom right hand side, you can see that all the white area is tumour and all the black stuff are the filaments of the filum terminale, completely surrounded by the tumour. And here's another patient. This is an unusual presentation. Patient with a pain in the neck, and there is an extensive tumour arising high up in the cervical region, but also there's another one lower down in the cord. This patient also had an MRI of the brain which showed this, which was a meningioma. This was a patient who had neurofibromatosis type 2, and the cord compression was the presenting feature in this patient, not the meningioma. This is a boy who had a neuroblastoma. You'll see that on this MIBG there is an area which might not normally be expected to be of high activity, and on the MRI there is a paraspinal lesion which has a significant intraspinal component extending into the right side through the intravertebral foramen. This is a boy who had neurofibromatosis, who presented into my clinic one day with a pain in the back of his neck and a bit of a lump. But he'd been playing rugby and he'd been in a scrum, and rather shockingly he'd developed an acute anterior compression of a cervical vertebra which had gone through a previously malformed vertebra, and this was causing significant pinching of the spinal cord. He went to Frenchy and had to be immobilized for about 3 weeks prior to surgical decompression, but he's fine since. This is a boy who had an osteosarcoma, whose chest x-ray showed some lower zone consolidation, and when we ended up doing an MRI because we were concerned about it, it was clear that he had apart from the lesion up in his thorax, he also had a lesion down in his spine which had completely eroded his lower lumbar vertebrae, causing significant compression. And if you see here in the axial images that the tumour again was extending into the spinal canal, so this is an extradural compression along the lines of the dumbbell neuroblastoma that I showed you before. So the message is that if you have a patient with back pain in childhood, unless you think that this is clearly a result of an injury or there's a clear history of something which explains it adequately, then it needs to be assumed to be dangerous and should be investigated appropriately. Thank you.